All right. I think we will go ahead and get started. So first and foremost, thank you everyone for participating in today's workshop, Hearing Loss and Fall Risk. Before I introduce our speaker for today, I would like to review some general rules for the workshop. So please stay muted for the duration of the workshop. You'll know that you're muted if you see a red flash through the microphone icon at the bottom of your screen. All of our workshops are being recorded, so if you do not wish to have your video appear in this recording, please go ahead and disable your video at this time. To ensure that you have a good view of our speaker, please select Speaker View. You can adjust this setting in the top right-hand corner of your screen. And then finally, please type any questions that you might have in the chat box. We will have some time at the end of the workshop for our speaker to answer any questions that you might have. So our speaker for today's workshop is Nicole Ferguson. Nicole is both the interim director of the Carle Center for Clinical Care and Education, as well as the director of clinical services and instruction in audiology at Central Michigan University. She received her undergraduate and Doctor of Audiology degrees from Central Michigan University. Dr. Ferguson has clinical experience in pediatric and adult diagnostics, electrophysiology, vestibular assessment, amplification, tinnitus, and teleaudiology. Oh, it's a mouthful. Please join me in welcoming Nicole, our speaker for today. Nicole, I'll go ahead and turn it over to you.
Thank you. Thank you very much for inviting me to speak with your group today. I appreciate it. And I just wanted to tell you a little bit about myself. I became an audiologist because I was experiencing dizziness myself as a teenager. And while my dizziness was diagnosed as something going on physically, vestibular became a strong interest of mine. So this is something that's near and dear to my heart. I would like to start with just talking about what is an audiologist and why is an audiologist talking to you about balance today. So audiologists identify, diagnose, and provide treatment for patients with both hearing and vestibular disorders. When you think of an audiologist, you typically think of audiological treatment, such as hearing aids and cochlear implants. And of course, that's primarily what audiologists do. But audiologists may also specialize in vestibular disorders, and they may work on fall prevention teams along with physicians and physical therapists. So it is not unusual that if you are getting a balance workup that you would be seen by an audiologist, because we perform extensive batteries of tests of the vestibular system. And depending on the finding of those exams, an audiologist might provide some management options. And in some cases, they would refer the patient on to an otolaryngologist, or neurologist, or physical therapist. So these pictures here just represent what you typically would see: an audiologist testing hearing, fitting hearing aids, and then the vestibular testing. And that's just very much in a nutshell what we do. I'm coming to you from Michigan. It's sunny out, but it's cold. And so I wanted to tell you a little bit about where I work. I work at Central Michigan University in the Carle Center for Clinical Care and Education. And we see patients of all ages, 0 to over 100. And we see patients for both hearing evaluations and vestibular evaluations, cochlear implants. Everything that an audiologist really could do, we do here at our clinic. There are 10 faculty members, and we are a primary training clinic for our Doctor of Audiology program on campus. And we will take anywhere from, at the low end, 10 students, at the high end, 18 students per cohort for training. These pictures represent the clinic, our fall, and then a couple pictures from our Fall and Balance clinic that I wanted to share with you. So what does the ear really have to do with falls? And I won't go too heavy into anatomy with you today, but I did want to give you some opportunity to understand why audiologists are in this world of fall and balance. So this picture is color coded. The ear portion that is orange is the outer ear, and the ear portion that is pink is our middle ear. So you're familiar with the outside of our ear, the pinna and the ear canal. Most people are familiar with the eardrum and the middle ear bones, which are our smallest bones of the body. And well, if there's a problem amongst these two portions of the ear, then there could be balance issues. But the bigger proportion of what's maintaining balance for you is here in the inner ear. And this is one part of the puzzle when it comes to balance. I'm sure you have probably heard that from other speakers. So I'll just stay focused on the ear for you today. But the inner ear consists of the cochlea, this snail-shaped structure. The snail-shaped structure, the cochlea, is really important for hearing. But the semicircular canals and the vestibules in this area right here, which aren't super defined in this picture, but these structures are important for your balance system. And then as you look at the nerve that attaches to that vestibule, and the nerve branches off to the cochlea, they join together and head up to the brain. And so our vestibulocochlear nerve is important for our balance as well. And so they're all very tied in together. And when an audiologist is evaluating a patient with dizziness, we're evaluating these portions of the inner ear, the vestibular nerve, the semicircular canals, and the vestibule. So we know that hearing loss is associated with falls, but vestibular disorders can also be caused by disease, injury, poisoning by drugs or chemicals, in other words, ototoxicity. They can be caused by autoimmune diseases. Traumatic brain injury can cause vestibular disorders, and general aging can cause vestibular disorders. They can also just be truly unexplained. The one big thing that we feel, though, that a causal pathway between hearing loss and falling is, I'm sorry, I'm going to reword myself here. Possibly the link between hearing loss and falling is interesting to us because hearing loss is highly prevalent but vastly untreated in older adults. And so we're going to talk a little bit about treating hearing loss and that can help you, how that can help you with falls. We're going to focus on how there are several comorbidities associated with hearing loss, ranging from loneliness all the way to mortality. And we also know that one key comorbidity associated with unmanaged hearing loss is an increase in falling. Specifically, how that can be a significant contributor to our health, our social, our economic, and our emotional consequences. So in general, I wanted to show you how we see hearing. I want to say hearing, well, I guess I want to say our hearing sensitivity, our ability to hear changes as we age. And that's just due to our genetics. It's due to the structure of the ear. It's due to use, in other words, exposure to noise over time. I'm going to go into that a little bit more in the next slide as to why, but I wanted to show you with this chart, a typical 20-year-old. If you look at this graph, we look at the low frequencies on the left-hand side to the high pitches on the right-hand side. We look at very soft sounds at the top and very loud sounds at the bottom. Now these are decibels. These are not percentages off here to your left side of the chart. So we know a person who's around 20 years of age will typically have normal hearing. They may even start to drop a little bit in the high pitches, but that's still normal. going into our 40s, they may start to show more of a mild high frequency loss. And it progresses from there as you go into the next 20 years and the next 30 years. We know that older adults, 65 years and older, are predicted to live more than half of their remaining years with at least mild levels of hearing loss. And more than half of the remaining life with a moderate hearing loss for those older than 75 years. So this is important for us to recognize that it's probably not something you're going to escape. 1/3 of Americans between 65 and 74 have hearing loss, and more than half of those, that hearing loss is significant. There are multiple issues linked to hearing loss in older adults, including increased risk of social isolation and loneliness, as well as an overall impact on health and well-being. We're also concerned about the potential risk of cognitive decline. We do know that hearing loss is one of the modifiable risk factors for dementia. I'm not going to go into that too deep with you guys today because we're talking about falls, but it is important to know that treating hearing loss can also significantly reduce your risk factor for dementia. Why all of a sudden, why do you start to lose your hearing? An age-related hearing loss, not due to specific disease or disorder, is due to the fact that we have these cells in our inner ear. They're called hair cells. You may have heard this from others. They are not hairs in the sense that we think of our hairs on our body, like the little fine hairs on your arm, or we do have hairs in our ear canal. We don't mean actual hairs, we mean cells that are shaped like hairs. So if you look at this picture, you can see that the cell is shaped like a little hair, a little string of some kind attached at the bottom. So this is a picture of those healthy hair cells in an inner ear. And this is a picture down here at the bottom of hair cells that are dying off. And what we know about hearing loss as we age is that we start to lose these inner ear hair cells. And as you lose those inner ear hair cells, you lose the ability to understand and hear what others are saying. I wanted to point out, remember I mentioned that the cochlea is a snail-shaped structure, and I promise this lecture won't be all about anatomy, but I do think it's important for you to understand that the snail-shaped structure is organized in such a way that the high frequencies that you lose first as you start to lose your hearing, the high-pitched tones, are the frequencies that are out here and the outside of the snail. And the low pitch tones, the frequencies that we tend to lose as hearing loss progresses, are further down in the snail. So what the theory is that as a sound wave travels through the snail, the higher pitches are being stimulated or used more than the low pitches. And over time, those hair cells wear out and degrade. And they really look at that in regards to noise damage models, but we know that it also exists within aging. So we know, as I've mentioned, that there are some consequences to age-related hearing loss. There just are things that are going to be harder to do. One is the ability to perceive speech. The other is that as the listening condition, in other words, the environment gets worse to hear in, as older adults, you perform worse than younger listeners. So if we are in background noise, that's what this graph over here is showing you. This first chart is normal hearing young listeners. The single talker is the white bar. And you can see it doesn't matter if you're a normal hearing young person, a normal hearing older person, or a hearing impaired older person, if there's only one person talking to you, you can understand what they're saying to you pretty well, regardless of your age, your hearing loss, so forth. But if we start to bring multiple talkers into the situation, such as a restaurant or a group setting, you will see that the normal hearing young people outperform the normal hearing older people. So if you look at the middle, the left graph, black graph, to the middle bar graph, black. Then you look at somebody who has hearing loss, it's just that much harder for them to understand when there's multiple talkers in the background. We also know that speaking rates make it difficult for older hearing impaired listeners to understand. So think about this like the tortoise and the hare. If you are talking super fast, then you need to take a minute to process what has been said to you and potentially fill in the gaps that your ear could not understand or hear. If we take a moment to slow down with our speech and give the brain a moment to understand what was just said, then the listener can hear better and understand better. The other thing that we find is that just age creates more difficulty for accented speech. And again, it has to do with having to put together the pieces of the puzzle. What exactly did that person just say? It's not just about being able to hear it, but then they have to process what was being said. And now we have to think about what masks are doing to speech for people in the real world. Even those with hearing impairment are having difficulty understanding exactly what somebody wearing a mask is saying. It's going to be that much harder for somebody with hearing loss. So we know that healthy aging is the ability for one to function within their environment. So if we look at hearing and communication ability, and we add in the demands of their environment, so our hearing and communication ability is, do you have a hearing loss or do you not have a hearing loss? If you have a hearing loss and we add the demand of your environment, let's say you are in a restaurant, you add those two together, that will create the outcome of fatigue and stress. So fatigue will increase as you increase both of those demands. In other words, if you increase hearing loss and you increase background noise, fatigue and stress will increase. It just will, no matter what. So we want to be able to maintain function within one's environment. One particular theory of aging is that old age is profoundly influenced by the physical environment in which people reside and how they cope with environmental challenges. So I'm getting back to balance. I promise I'll get back to balance, but I wanted to give you some ideas about hearing loss and why hearing loss can add to challenges as we age. We just know ultimately hearing loss will create fatigue. It can create a mental or a physical weariness, resulting in reduced alertness and a range of emotions and behaviors. It's an adaptive state commonly reported with many chronic conditions. So in other words, fatigue is present with many chronic conditions. Those who seek help for their hearing difficulties are more likely to report low energy and increased fatigue. I can't say it today. Are depression, lack of desire to engage in life activities and social interaction. If it's ignored, it can lead to a decline in numerous functions and health problems, and it can have a negative effect on quality of life. So let's get us back to balance. According to a study done by Johns Hopkins, Individuals with untreated mild hearing loss were nearly 3 times more likely to have a history of falling. So why is this? They also have found that using hearing aids for 30 days can reduce the risk of falls. There are some very small studies out there promoting the use of hearing aids as a way to improve balance and presumably reduce the risk of falls. They claim that hearing aids can act as auditory reference points or landmarks to help one maintain balance. They have found that the number of seconds a patient maintained stability when using hearing aids was notable. Beyond diagnosing the level of hearing loss and appropriate connection, an assessment of gait and balance with specific recommendations may prove to be equally beneficial. So when we think about fatigue can increase our risk for falls, but we can also look at that we're missing information. So what this study is really looking at is, are we missing information to tell us where we are, reference points in our environment? So it's a little bit like using your eyes to tell you where you are in space. If we turn out the lights, people will sway a little bit, more than they would if they could see. And this is because our balance system is tied highly into our vision. Our vision helps us maintain our balance. So if you take away one, you may find that it's more difficult to manage the other. The study also suggests that opening your ears can also give you information about your balance. So we really would focus on, as an audiologist, our treatment is treating the hearing loss, even if it's mild. We would also want to utilize we would want to assess our social network size and work on identifying loneliness, listening effort, and fatigue. And really, hearing healthcare focuses on optimizing social engagement. Intervention within our social environment is tailored to a patient's need, and we should also be clinically, audiologists should be screening for hearing loss when evaluating dizziness. We should not just be looking at one part of the ear. So our recommendation is sensory stimulation. In other words, hearing aids. If there's a hearing loss, we would recommend fitting hearing aids. But what we know, the reality is only 20 to 25% of people with hearing loss actually obtain hearing aids. And those with hearing aids aren't using them regularly after 1 year. Why is this? Cost, health, family, life, and technology. The big one, though, we know is stigma. Hearing loss stigma, it only happens to old people. Untrue. It happens starting in your 20s, and it gets worse from there, people. And some people can't stop it. It's genetic. It's what is occurring from your occupations or from your hobbies. Hearing aids are unsightly. The manufacturers are working hard to make hearing aids more attractive. I would argue that there's a lot of people wearing things on their ears for their cell phones these days that are less attractive than hearing aids. So it's just another part. I have patients who tell me they wake up in the morning and they put all their pieces and parts on. I can identify a little bit with my contacts or my glasses, but you know, if you're starting to add a cane and hearing aids in there, I can appreciate where they're all coming from. And others feel that nothing can be done to help. And I would argue that's not the case. We have lots of options. If we go beyond what hearing aids can do, we can move on to cochlear implants. And age is not a barrier for cochlear implants. Of course, it's a surgery, but we have a lot of older adults getting cochlear implants in our clinic. The key thing is the earlier you manage your hearing loss, the better your social outcomes are, and your whole health outcomes really are, the earlier you manage it. I wanted to show you sizes of hearing aids, just so you had an idea. There are different sizes. There's everything from large behind the ears that you're probably used to seeing long ago. They have been making those behind the ear hearing aids smaller and smaller. Quite frankly, what we most often fit in our clinic is what we call the RIC, receiver in the canal. It's a tiny piece that goes behind the ear with a thin wire going down into the ear canal. And the reason for that is it actually is pretty darn discreet. You can barely see it in this picture, and it's not really because the picture is blurry. It just really is that discreet. But also it doesn't plug up the ear canal. And one of the major complaints of hearing aids from patients is how much their ear canals plug. So that's probably our most common fit, but there are also the in the ear models as well, down to the IIC, invisible in the canal. And this fits really small down into the ear, deep down into the ear canal. Now I'm speaking to you from Michigan, and I can't speak very specifically about California, but I often get asked about cost of hearing aids. And I will tell you, in my region, now I live pretty rural in Michigan, but our hearing aids at the top end are about $5,000 for a pair. They're expensive. Medicare does not pay for hearing aids. You might have you might have an insurance supplement that does help pay for hearing aids, but Medicare itself does not pay for hearing aids. In Michigan, Medicaid does pay for hearing aids for adults 21 years and older every 5 years, and they must meet standards of coverage. And I left this in here only because I know that we had adults under Medicaid, excuse me, for years and years and years, and then it went away for years, and it came back under the Affordable Care Act. So I don't know what California does. I don't have a clue. Quite frankly, I just wouldn't know, not being a practitioner in California. But I thought there's the potential there, and so it's worth asking somebody local in your own case. If you're a veteran, then you can either enroll in VA healthcare, or you can become service connected for hearing loss or tinnitus, and then you can obtain hearing aids through the VA for free. We also utilize the Lions Foundation of Michigan for some of our patients who are unable to afford hearing aids and do not qualify for Medicaid. And you may have something similar in your area too. So again, I wanted to leave that up there because the Lions clubs missions are both hearing and vision. And so you may have a resource like that locally as well. A lot of times people are resistant to hearing aids because they come with a lot of maintenance and care. So I just wanted to acknowledge that's absolutely true. There are little electronic devices that we stick in a moist, wet cavity, and we expect them to work over 12 hours a day for us. And so we do have to maintain them. You do have to potentially change the batteries or recharge them every night, just like you would with a cell phone. They do need to be wiped off. They will collect wax. You may have a little small wax trap on the end that needs to be changed daily. And they need to be put away from moisture. Remember, they're an electronic device. And then there might be some yearly checkups. Actually, we like to see our patients here every 6 months at least. Occasionally, we have patients who recommend 3 to 4 months returns as well. So hearing aids are not necessarily, there are over-the-counter products being developed. And I think that there's definitely some patients who will fit within the range of appropriateness for that. But a lot of people need additional help and should have good help from their healthcare provider, their audiologist, on maintaining those hearing aids for them. There are also accessories available that go in addition to hearing aids, and I just wanted to mention these so you knew about them. These are external microphones that directly connect to their hearing aids. So these ones up at the top, the red, white, and blue, or the red, silver, and blue, these are external microphones designed to look like a pen, so you could just hold it out in front of yourself, or you can wear it around your neck. The circle one is meant to sit on a table out in front of you. Anytime you can get a microphone closer to what you want to hear, the better you will perform. And that's what you're seeing too with the TV there, is a device that plugs into the TV and goes directly to the hearing aids. There are assistive listening devices. If hearing aids are just way too expensive and unavailable, then there are things that connect directly into the TV and can be worn around your neck. Headphones with a microphone that can pick up the other person around you. You can get strobe lights for your smoke alarms. You can get large display alarm clocks with a vibrator for your mattress to wake you up. It can also be tied in, as you can see in this alarm clock, it's actually saying fire, so it can be tied into your security systems, your alerting systems in your homes. And there are also, I wanted to mention, T-coils or loops. If you've ever gone to a public theater, you may have seen this universal sign for T-coil. Many hearing aids have what we call a T-coil in them, and you would just switch your hearing aid into T-coil, and then that particular system's, the theater system, will go directly to your hearing aid and help you understand better as well. Some other options that are of no cost to people are Caption telephones, and these are available to patient or to anybody who has a hearing loss under the Title IV of the American Disabilities Act. You have to have a hearing loss, high-speed internet, an electrical outlet, and a standard dial telephone service. But others can call you direct, and you would receive closed captioning real time as you're talking to that person on this video screen here. You do have to have a health professional, such as a physician, an audiologist, sign a form for you to get one of these phones, but they are available. There are also apps that are helping people. Closed captioning, we all have probably seen closed captioning that comes across a little bit funny, but it's getting better. We know that Google Live we can have transcription through Google Live. Microsoft Translator. This one's really interesting. This is a picture of a tour guide talking into her cell phone, and then you can see the gentleman over to the left is listening to her, or not listening to her, he's reading what she's saying in his Russian language. So I think this is just fabulous. This isn't specific to hearing loss. You could have it, she could be talking in English and you could have your phone set to English. So it's just another resource available to you. If you Google Caption, it will come up on your phone. I mean, it will come up on your phone or screen. So a couple last things before I'm done with you today. I just wanted to talk to you about some good communication strategies. Louder is not always better. So don't shout necessarily. Get down, as we talked about, as we age, the ear degrades in its ability to decipher in background noise. It needs a slower rate of speech. It needs clarity. Accented speech or masked speech is going to be more difficult to understand. So getting a person's attention with a tap or a wave. If you're changing the topic, acknowledge, oh, I wanted to tell you this. It's not related to what we were just talking about. Do speak with them as face-to-face as you can. We don't want to shout or clap. We don't want to speak with your head turned, and we don't want to speak rapidly and loudly. If they do mishear you, if you get the inevitable what, try to rephrase what you've said with different words instead of saying something along the lines of, let's go over here. You could say, let's go up and pick out our lunch or something like that. I don't know. I'm just coming up with something off the top of my head. You could remember to be patient, keep trying, use handwritten notes if possible, and try not to get frustrated or say it's not important. That just ends up dismissing the person. It can make them feel, left out of the conversation. And then a couple things the same types of things apply when wearing a mask. Speak clearly. This one says loudly because we do have to get over the fact that there's a slight barrier, but not shouting, just louder. Try to rephrase rather than repeat. Use your eyes to enhance your message. Use body language and hand gestures. And try to augment with written tools. And I would argue that I'm struggling even with somebody with normal hearing in this day and age of people with masks myself too. So we all need to be patient with each other. And I did kind of race through that, so we have lots of time for questions and answers. And I will open it up to that.